There are certain points to be noted regarding the cervical cancer staging. Imaging and pathology can be used when available to supplement clinical findings with respect to the tumor size and extent in all stages. So, using imaging and pathology, we can decide the cervical cancer staging. So the involvement of vascular and lymphatic spaces will not change the staging. The lateral extent of the lesion is no longer considered. Adding small r for imaging and small p for pathology to indicate the findings that are used to allocate the case to a certain stage 3C. For example, if imaging indicates pelvic lymph node metastasis, the stage allocation would be stage 3C, 1R, and if confirmed by pathological findings, it could be stage 3C1P. The type of imaging modality or pathology technique used should always be documented. When in doubt, the lower staging should be assigned. This is a picture of cancer stage. You can see the left side, first one is the normal cervix as seen through colposcope. Second picture is stage 1 where the cancer is confined to the cervix. Next one is stage 2. Third one is stage 3. And the fourth one is the stage 4 where it has spread outside the pelvis. Now, prognosis of cancer cervix. It depends on many factors. The first one is the stage of the lesion at the time of diagnosis and initiation of the treatment. Higher the stage, prognosis is poorer. The next is the depth of invasion. The invasion is less than 1 centimeter, less chance of lymph node being involved, and thus there is a better prognosis. Also, the tumor size. The tumor size, if it is less than 4 centimeter, then less lymph node involvement is seen and is a better prognosis. The type of cancer, when it is well differentiated squamous cell cancer, this grows slowly as compared to anaplastic type. So this has a better prognosis compared to anaplastic type of cancer. In case of endocervical infiltrative type of cancer, the diagnosis is late, and because of that, prognosis is poorer. If the patient is of a young age, generally they have poorly differentiated cancer and they have poor prognosis. If there is an involvement of lymph nodes, pelvic and para-aortic, survival rate reduces by 50%. If a younger patient has HPV positive, this shows better prognosis. This is a chart of cancer survival. When a diagnosis is there of stage 0, the 5-year survival is 92.8%. Stage 1A, it is 93.2%. If it is 1B, 80.3%. As seen, as the stage becomes more, the survival becomes less. Stage 2A, survival 63.2% by 5 years, and stage 2B 58.0%. Stage 3A and 3B is 35.4% and 32.4% respectively 5-year survival. The 4A stage is 16.1%, whereas 4B is 14.6% only are survival by 5 years. What is the differential diagnosis? One is cervical tuberculosis, then it could be a syphilitic ulcer, cervical erosion, fibroid polyp, and incomplete abortion. The complication of cancer cervix is there could be hemorrhage, sometimes even while examining itself in a higher grade stage, there can be very severe hemorrhage. In case there is a stenosis or narrowing of the cervical canal because of cervical cancer, it may lead to collection of fluid in uterus which can get infected and it can cause pyometra. Infection is also quite common. In case it involves the ureter or kidneys, it can lead to uremia. Patient may have cachexia in later stage, and if it extends to bladder or rectum, it can cause fistula and it can cause vesicovaginal fistula or rectovaginal fistula. The cause of death could be sepsis, or it could be because of cachexia, uremia, hemorrhage, or metastasis. Metastasis causing the organs where it is metastasized. Maybe there will be liver failure or renal failure, and it can lead to death. Management. Management, primary prevention and secondary prevention. Primary prevention is by screening, regular routine screening by pap smear, and in high risk cases you can do the HPV test also, and can diagnose the cancer or precancerous stages and take appropriate methods to prevent further worsening of the disease. Barrier contraceptive is also prevention of cancer because the HPV infection is not passed. Another thing is vaccination, and vaccination will prevent cancers caused because of HPV, but not all cancers. So the patient will need to undergo pap smear. Routine pap smear should be continued. Then total hysterectomy whenever advisable for any other pathology in the uterus. Maybe it's a fibroid uterus, or maybe it is a abnormal uterine bleeding. So for that case, when hysterectomy is being done, it should be done total hysterectomy, that is even cervix should be removed, and that can prevent cervical cancer. Secondary prevention is when you diagnose, identify the disease in early stage, we have to treat it. So routine screening can, as already mentioned, can diagnose cervical cancer in early stage. Treatment of cancer cervix. It can be primarily surgery, or primarily radiotherapy, or primarily chemotherapy, which is supported by or added to other therapies. So it can be a combination therapy. Maybe initially the surgery is done, and then later on, if required, radiotherapy is given, or radiotherapy is done initially to reduce the size of the tumor, and followed by surgery. Chemotherapy, whenever is required, can be given. In case of cervical intraepithelial neoplasia or pap smear, by pap smear when it is diagnosed, then it's followed by routine screening and appropriate tests are done. If the routine screening is normal, then you do the regular followed by again routine screening as advisable. If the pap smear is abnormal, then we do colposcopy, and colposcopy directed biopsy is done. In CIN1, followed by biopsy. If biopsy is normal, the result of biopsy is the normal, then again follow it up by routine screening. If it is abnormal, then we can do conservative type of treatment where we retain the cervix, especially when patient wants to have fertility. In CIN2 or 3, we can again do conservative treatment by LEAP and excise part of that transformation zone, or treat it with cryotherapy or cone excision. The definitive treatment can be done by hysterectomy. Cervical cancer treatment for stage 1A up to 2A. We do radical hysterectomy with therapeutic lymphadenectomy. Then in high risk groups, we add radiotherapy with concomitant chemotherapy. From stage 2B to 4A, we give primary radiation by external beam or brachytherapy. Stage 4B is a palliative treatment plus chemotherapy. We give combination of paclitaxel, cisplatin and ifosfamide. So this is the basic plan of treatment. I'll just explain it with some more slides. You can say stage 1A to 2A radical hysterectomy with lymphadenectomy, 2B to 4A primarily radiation and then external beam or brachytherapy. What it is I'll explain. And 4B is palliative with chemotherapy. Before that, cancer with pregnancy. Cervical cancer with pregnancy, if it is an early pregnancy and patient is willing for termination of pregnancy, then stage 1 or 2A, we can go ahead with again radical hysterectomy and therapeutic lymphadenectomy. If patient is near term and wants continuation of the pregnancy, she is not willing for termination, then we can counsel the patient regarding maternal risk and let her continue till term. So when pregnancy is with cervical dysplasia or CIS, carcinoma in situ, then we allow normal vaginal delivery. In case of pregnancy, carcinoma and stromal invasion is there, near term, we can do cesarean section, and after that appropriate treatment is given for cancer. If it is further progress, then we have to do cesarean hysterectomy and therapeutic lymphadenectomy once the baby is mature. So cervical cancer has medical management consisting of chemotherapy or invasive hysterectomy, then radiation to treat and prevent recurrence. And what is type of radiation? It could be external beam or brachytherapy. Brachytherapy is radiation is placed near the tumor. It's intracervical or intravaginal. And other type is chemotherapy and close follow-up has to be done. One word about microinvasive carcinoma. Microinvasive carcinoma is defined by FIGO as invasive carcinoma which can be diagnosed only by microscopy, with deepest invasion is less than 5 millimeters and largest extension is 7 millimeters. Following the advent of cytological screening, the proportion of invasive carcinoma that invade less than 5 millimeter increased more than tenfold to about 20% in the United States. Lesions that have invaded less than 3 millimeters are rarely associated with metastasis. 5 to 10% of tumors that have invaded 3 to 5 millimeters are associated with positive pelvic lymph nodes, that is stage 1A2. So to revise, the early stage treatment, stage 0 is local surgical removal, that I told you, cone biopsy or LEEP. Stage 1 to 2A will be operation, that is hysterectomy with lymph node sampling or therapeutic lymphadenectomy, followed by radiation depending on the histopathological finding, plus or minus chemotherapy. That chemotherapy and radiotherapy is in high risk. Which are the high risk patients? High risk patients are patients with tumor more than 4 centimeter, or lymph nodes are positive, or the margins are positive. Margins of the tumor, margins of the hysterectomy specimen are positive. They should receive the adjuvant chemotherapy and radiation. Now further 2B onwards. So 2A up to 2A is radical surgery and chemoradiation. Stage 2B to 4A, combination of radiotherapy, external beam chemotherapy and invasive therapy. 3A and 3B also same, chemoradiation therapy. 4A also same, up to 4A. Now 4B, I told you, palliative treatment with chemotherapy. Sometimes some pelvic radiation therapy to control the bleeding in the vagina. Chemotherapy is for distant metastasis. To explain the surgery, some terms which are used. So radical trachelectomy. What is radical trachelectomy? Removal of the cervix and part of the vagina and the lymph nodes in the pelvis. This is recommended for a small number of women with small tumors who are interested in having pregnancy in the future. The next is total hysterectomy, that is removal of cervix and the uterus. What is radical hysterectomy? Radical hysterectomy is removal of the cervix, some tissues around the cervix, the uterus and the part of the vagina. Often it is associated with removal of fallopian tubes and ovaries. So when you remove fallopian tube and ovaries, then you call it salpingo-oophorectomy. The lymph nodes, the surgeon may remove the lymph nodes near the tumor to see if there is cancer in the lymph nodes. So if the cancer cells have reached the lymph nodes, that means disease has spread to other parts of the body. So this is the radical hysterectomy with lymphadenectomy, therapeutic lymphadenectomy. So even if the lymph nodes may be negative, they are removed. They are removed because you have to see by histopathology if it is positive. So then the staging may change.